Yes, we are on air. Good morning, good morning. Good morning, everyone, and welcome to this highly anticipated webinar on molecular syndromic diagnostics in pediatric and neonatal population, a clinical approach. My name is Emily Martin, and I'm honored to serve as your moderator today. At Fermentex, we are dedicated to advancing healthcare through innovative solutions and meaningful knowledge sharing. This session aims to shed light on how molecular syndromic diagnostics can transform the clinical management of infectious diseases in pediatric and neonatal population. We are delighted to welcome Dr. Arias, a distinguished Pediatric Infectious Disease Specialist, as our guest speaker. Dr. Arias brings a wealth of expertise and experience holding key positions at Hospital Universitario Erasmo Muñoz, Clinical Medical Duarte, and Clínica Santa Ana. He also served as the Medical Director of InfectoPEPS and Infecto Norte, and is the faculty member at the Universidad de Santander and the Universidad de Pamplona. With such an accomplished background, we are confident that his presentation will provide valuable insights and inspire us all. Before we begin, a few housekeeping notes. The webinar will run approximately 1 hour with a dedicated Q&A session at the end. Please feel free to submit your question at any time via the chat or the Q&A box. I will ensure that they are addressed during the Q&A session. To our attendees across the various Caribbean islands, thank you for making time to join us today. With further ado, let me welcome Dr. Arias. Dr. Arias, the floor is yours.
Good morning, everyone. Can you confirm me, please, if you're listening?
Yes, we can listen. Thank you.
So, I will share my screen right now. So, we'll check if it's in order. So, everyone can see.
Yes, we can see.
So let's go starting with molecular syndromic diagnostic. This is my conflict of interest, but as you will see, it's all based on evidence. So I'm right now directing physicians in my country in ID diagnostic, and it's my biggest interest conflict. So these are the topics for today: antimicrobial stewardship, real case scenarios, and how to integrate molecular diagnostic in ASM, the workflow proposal, and the take-home message. So what is antimicrobial stewardship and how can we improve it with molecular diagnostic test? So it is defined as a program to change and direct the use of antimicrobial agents. And you know, there are several organizations worldwide that are behind this installation and implementation of the program. So it's a global action plan in the WHO, and we must be doing our diagnostic test according to these programs and with the support of ID every time. So in my country, we have these regulations. I hope yours have too. And what we are looking for in the antimicrobial stewardship is trying to look for antimicrobial misuse if we're treating with antibiotics viral pathologies, if we're treating with antibiotics non-infection causes of disease, if it is prolonged duration, what we are having the patient, or if we are treating with broad spectrum antibiotics, what we must do with less coverage for the same pathogen. You have to remember that antimicrobial stewardship works in a continuous frame of work with the clinicians, surgeons, with PharmD, and with microbiologists. So, having in mind that antimicrobial stewardship will be our leading strategy to have a proper implementation of molecular testing, in brief slides we will have the data of molecular tests. You know that molecular tests are usually intended to diagnose or to detect pathogens that are included in the test. And we have closed or open platforms and newly platforms in the market that are multi-target or multiplex, usually nested, and closed platforms that allows to have less pre-analytical interference with the results. It allows us to clinicians to move from medical school to real practice. So we have clinical syndromic approach, and after the test we could have etiological diagnostics. It is important to always make sure that we have the ideal patient. We are adhering to an institutional algorithm. We have support decisions with ID specialists or the microbiologist team, and that the molecular test is integrated in a critical alert value. So you know that for molecular testing, time is essential, so you can have results and you can take decisions on the bed, the patient's bed, like a POCT test, point of care testing. So you can do decisions based on your result. And for you to know, even a negative result in molecular testing could give us tools to make a decision, a better decision for our patients. The molecular test has to fulfill these assured criteria, and it must be accessible for the population, sensitive enough, specific enough, so we can compare with gold standards and we can have an improvement in time and in the sensitivity of the test, that is friendly, easy implementation for the labs, fast, robust, free of high-tech equipment and infrastructure, and this is essential so we can have molecular testing like POCT for every patient in every scenario. That is delivery to at-risk population, so every patient we have on our ER or in the PQ, NICU, or the emergency department. What I think is the most valuable point for bioMérieux is that it offers updating and it teaches how to use their technology. So it is really important because you can have the technology, but if you can't use it well, it is going to be lacking of interest for the clinical interpretation, for the clinical use for everyday treatment in our patients. So there are several platforms. I want you to know that not only FilmArray is in the market, but they share something in common. They can detect a lot of pathogens, and they have this time frame for the result, almost 1 hour, maximal 2 hours, and this is important to have a better approach on our patients, like a PCOT test. They are always nested multiplex, at least in BioFire or FilmArray platform, and what you can see is that you can detect a lot of pathogens, at least these are respiratory samples, and also atypical bacteria that otherwise cannot be detected in normal or usual microbiological test. When I ask my ID doctors in my country what is important to look when we are choosing a molecular test for our patients, I want you to look at this. Number of targets. Having a syndromic multiplex platform, it's really important. It's almost the most important thing that an ID looks in a test, in a molecular test, and that could be rapid, robust, with high specificity and sensibility, so we can deliver a correct result to our patients. And the cost is one of the less interesting things when we can have targets high enough to make a clinical and etiological diagnostic, and when we can have time and specificity and sensibility in our patients. These are the panels that FilmArray have already. This is respiratory FilmArray panel on nasopharyngeal swabs. This is the meningitis encephalopathy panel, the BCID for sepsis and blood cultures. This is the FilmArray panel for pneumonia. This is the newly launched panel this year for bone and joint in articular samples, and this is the GI FilmArray for gastrointestinal samples. So as you can see, you can have a clinical approach, and after the clinical approach, when you are suspecting the source of the infection, you can have molecular diagnostic syndromic diagnosis with this PCR. These are the pros, these are the cons for choosing a PCR. And as you can see, having nested syndromic molecular tests are fast, are sensitive, can detect viruses almost more sensitive than what we used to know. You know that immunochromatographic tests that were used for influenza, were used for COVID, has limited sensitivity, almost 50-60%. You can detect bacteria, you can detect typical bacteria. It's a friendly format, and you can have also in BCID panel and in a pneumonia panel resistant genes, so you can really targeted or direct therapy to suspected resistant microorganisms. It can help to target or direct antimicrobial therapy, can be linked to software for real-time monitoring like Real or other software that are available in our countries, and can be and must be implemented as a critical value alert. You know, I always teach my residents and my fellowship training pediatricians that molecular tests are like a trampoline. It must be informed as soon as you have the result, so the clinical physician can make decisions on the bed of the patient. It decreases diagnostic error, and it decreases the need for trained personnel because it's a friendly platform, and it does not need a high level infrastructure, so you can implement the test. You should know that these molecular testing are limited of the target, so when you choose a molecular test, you must, or is preferred to choose the best approach that includes the highest number of targets in the test, so you can have a more rational approach into the diagnosis of the patient. It has gene of resistance, but does not directly relate to the activity of the gene and the expression of the gene. At least it is what is expected in FilmArray pneumonia. But in BCID panel, if you are seeing the gene, you probably doesn't ignore the resistant gene. It is cost effective. You know, it is more expensive than normal testing, but has a lot of more sensitivity, specificity, and when you summarize all the benefits for the patient, all the benefits in epidemiological aspects, as we will see in the environmental hospital, it will definitely has this cost effectiveness related to the test. The sensitivity and specificity of each test is variable, so you have to choose the best platform in the market, and depending on the test, the report may be altered if the pre-analytical manipulation of the samples have to be involved with very manual structure, you know, like open PCR, that you have to do the denaturalization process in an open resource. You have to make the mixture in an open resource, so you can have contamination, cross reactions. So when you choose these platforms, at least in FilmArray, you are making it a closed platform, so you are like having the security that the pre-analytical phase, if the sample is well collected, is going to be really secure, and the result is going to be related for what the patient have in the consultation. This is an example of a hospital assembly, and as you can see, all the magic occurs here. So what you have to guarantee is the sample is taken correctly. After that, you only deliver to the laboratory, and in 1 or 2 hours, you are going to have the result, and all the amplification is going to be made here in these platforms. There are another technology also from bioMérieux that this year is going to be launched, at least for respiratory diagnostic, so you can have more quickly results, but this is also molecular testing. So how to integrate antimicrobial stewardships and molecular testing in the fight against resistance and in having a correct diagnosis and correct treatment for patients. So we're going to have this daily practice approach, and I hope it's something you're also watching and having in your clinical practice. So this is normal workflow. This is what we also are doing every day, and what we have to do when we don't have molecular testing. We do a clinical suspicion for our patients, and we try to do a syndromic clinical approach. We start on empirical treatment our patients with antimicrobials. We have conventional tests, and we only can have 3 results with this conventional test. A lot of time for the results, and we can't have detection of atypical bacteria, perhaps less sensitivity of immunochromatographic tests for viral pathogens, and limited for the number of targets of the test. We can have a quick diagnostic for fungal pathogens, so this is absent usually in the normal workflow of the patients. We have limited diagnostic performance of the test, as we will see. It is really important in pediatrics clinical scenarios where we don't have a lot of specimens for testing, like we don't have a sputum like we do have in adults population, for example. And we have this clinical reality. We have failure in identification of usual pathogens with conventional testing. So it leads us to misdiagnosis, to inadequate antimicrobial coverage, to resistance, generation of resistance. There is a phrase in our country that what you don't kill, you select, and you select that kind of resistance. And finally, we will have impact on hospital economy and adverse events for our patients. So let's do it. Let's make clinical case scenarios. This is a term baby of 26 days of age at admissions, with 2 days of fevers, with a sibling that was also sick of respiratory symptoms, with his vaccination card for Colombia with hepatitis B and BCG, and maternal vaccination only with tetanus and pertussis. He was admitted with respiratory distress, rhonchi at physical examination, and this is his weight at admission. So our first diagnosis will be at least perhaps bronchiolitis or late onset sepsis, right? So if we're trying to avoid or making the approach of late onset sepsis in these patients, we must search for the focus or for the clinical area that is making the clinical picture of our patients. Perhaps in the most conservative scenario, we will see or we will make the diagnosis of bronchiolitis. But as you can see, our patients could have deterioration, and this patient had deterioration in the next 24 hours. He was tachycardic, tachypneic. He had to be transferred to NICU, and he has to be started on CPAP and high flow nasal cannula. As you can see, this is the high flow nasal cannula, this is the patient, these are the subcostal retractions, and the differential diagnosis at this time in the NICU was pneumonia causing sepsis, so superinfected bronchiolitis was suspected, and initial treatment with ampicillin was started. The workflow included blood cultures, included chest X-ray, as I will show you, and included, of course, urine gram and urine culture, because the most common bacterial superinfection in bronchiolitis in neonates is UTI. And if you're going to make the completed workflow, you have to include lumbar puncture if you're treating a late onset sepsis in neonates without a source. But let's start saying that this patient has these focal findings, respiratory focal findings. And as you can see, this is the chest X-ray of our patient, and these are the infiltrates. And this is true for bronchiolitis. You can have infiltrates in all the chest X-ray, or you can have a normal chest X-ray, and it is going to be bronchiolitis. But with this chest X-ray and with the clinical deterioration that this patient had, the NICU considered a community-acquired pneumonia, and they changed ampicillin for cefotaxime, and they made the consultation to us, to ID. This is the paraclinicals, the lab test. These are low risk paraclinical tests, and as you can see, blood cultures were without growth at 48 hours, and even with those laboratory tests, the antimicrobial were maintained for NICU. What we did in the consultation was ordering a respiratory panel, and this was the evolution for the patient. It quickly has low respiratory requirements, no other deterioration, blood cultures persistent negative, and low risk laboratory tests. As you can see, even a procalcitonin was negative, and we had the detection for metapneumovirus and for rhinovirus. You know that metapneumovirus is a cousin for RSV, and it can cause viral pneumonia. So what we did was, in our final conduct, suspend or stop antibiotics, making the diagnosis of bronchiolitis for metapneumovirus and rhinovirus. The surveillance of the patient was always conducted in the NICU. And what is important to you to know is that we also made this patient on isolation. Metapneumovirus and RSV has this transmission mechanism of contact. So if we don't know the pathogen, we don't start isolation precautions. And if we don't start isolation precautions for metapneumovirus or RSV or SARS-CoV-2, we are going to have outbreaks in our NICUs, and the outbreaks are going to have this clinical impact and even death for our patients. So these are utilities that are included in the panel, that if you make the correct interpretation for the panel, you can have a clinical impact and also an epidemiological approach for the patient. So, virus or bacteria, what will you think if you have this patient as good as he looks? With this clinical scenario, he was admitted with 1 day of fever and cough, and this is a preterm baby. His evolution after 1 week of birth was really good. He recovered his birth weight, and the only symptoms was fever and a cough. As you can see, low risk paraclinical diagnostic using what we have, including procalcitonin, and the normal workflow for this clinical picture will be trying to make the differential diagnosis between bronchiolitis or late onset sepsis. So, because of his symptoms, a chest X-ray was made, clinical bronchiolitis diagnosis was performed, but with this chest X-ray, with these infiltrates, these opacities, the suspicion was changed for bronchiolitis superinfected with a community-acquired pneumonia. So when you say this, you are also starting on antibiotics, and NICU started ampicillin and amikacin. But the patient was looking like this, and these were these laboratories. So what we did in antimicrobial stewardship in our clinical rounds was making or pursuing the diagnostic, making this respiratory film MRI, detecting rhinovirus. You know that rhinovirus is nowadays described as a cause of upper respiratory infection and also clinical pneumonia. So with this good looking appearance of our patient, the surveillance that we can do in our NICUs and the correct diagnosis made on the bed of the patient, what we did was stopping antibiotics and only maintaining the clinical surveillance in our NICU. And this has an impressive outcomes for the patients. We are trying to stop adverse events after antibiotics, and we are not modifying his microbiome. You know that microbiome has a well-described role nowadays in the clinical scenario. So when we make the prescription for antibiotics when these are not needed, we're going to have patients more propense to allergic diseases, to asthma, to modifying the clinical scenario for they in the future, so they can have eczema, altered comportamental behavior, and this is all related. When we don't have diagnostic, we are going to have this propension to initiate antibiotic for all the things that we are admitting to our NICUs. So this is not what I want you to have in mind all the time. Of course that there are viruses, but of course that we have also bacteria. So this is a newborn that was admitted in our NICU since birth, and his admission was first conducted because of he had this laryngeal stridor. So we were suspecting heart disease, and this was later confirmed on the echocardiogram. But of course, in admission with respiratory distress, it was started on antibiotics with ampicillin and amikacin on day 3, and with the confirmed cardiopathy in antimicrobial stewardship, we suspended antibiotics. But as you can see in the clinical evolution of our patient, it had a failed extubation due to stridor and bronchospasm, but the chest X-ray had this rapid deterioration. In less than 24 hours, we had these infiltrates and opacities in both apical segments of the lungs. The workflow and laboratory test results were of high risk, aprocalcitonin positive, leukocytosis. So we did the diagnostic of pneumonia, but in this context, with 8 days in the NICU, you have to be really aware of hospital bacteria. So he was later intubated, and we did indicate gram culture of this endotracheal tube and the pulmonary pneumonia, and we adjusted cefotaxime because we were thinking we did not have risk for pseudomonas. So we adjust therapy to cefotaxime, and as you can see, Klebsiella pneumonia was detected, and we were really assurance of what we were doing with cefotaxime, and with normal susceptibility test and culture later in the evolution of the patient. With the culture result of the susceptibility test, we also had this Klebsiella pneumonia isolated, and it was a wild type sensitive susceptibility proven to cefazolin. So we changed the patient of cefotaxime to cefazolin, and we end therapy with cefazolin. So my next advice to you is that molecular tests can give us really quick information, but it is a complement test for routine microbiological testing. You know, you can have the detection really quick, but you can, with susceptibility test, you can have the clinical scenario of direct therapy according to what the culture gives to you. Of course, the culture is later on, so you can have, or you must have, this interplay between both testing, the molecular test and the normal culture test. But you don't always have expected bacteria. What I want you to show you here is a day in 8 days neonatal patient that is a extremely premature neonate. He was his delivery by C-section with 26 weeks of gestation for his mother. The C-section motive was eclampsia in his mother, and as you can see, he was started on ampicillin and amikacin for early onset sepsis, but he was unresponsive during the evolution. He has clinical deterioration, he has clinical X-ray deterioration, even with 2 surfactant doses, and the diagnosis was made for bilateral pneumonia. I want you to show the chest X-ray that we had. I don't know, this is the chest X-ray, and as you can see, he's intubated with a really deteriorated chest X-ray with opacities in all the lungs, in all the focus of the all the segments of the lungs of this neonatal patient. So when you have a patient that is not responsive to ampicillin and amikacin, that you can call like the first line of therapy, ampicillin gentamicin or ampicillin amikacin, you usually will change to cefotaxime linezolid, for example. But look what we had in our test. In our molecular test, we had the detection not only of coronavirus, that perhaps was a transmission of their family or our healthcare workers, but we also had the detection of Acinetobacter baumannii complex. You know that in NICUs, Acinetobacter is not really an usual pathogen. We are not thinking in Acinetobacter when we are routinely making the coverage of loss or EOS. Not in early onset sepsis, not in late onset sepsis. We are thinking in Acinetobacter. So if we only will sustain cefotaxime linezolid, we will not be covering Acinetobacter. What we could do with the molecular testing is that when we see this, we change our conduct, our antibiotic coverage to ampicillin, sulbactam, and cefepime. So we were treating the correct pathogen in a rapid time, so we can save the life for the patient. And what we also could do was initiating isolation for the patient, like contact precautions is essential when you see Acinetobacter, and making the alarm of the outbreak that we were having, because when you see Acinetobacter, you're having cleaning, disinfection, environmental disinfection process altered, so you must review what you are doing in the environmental disinfection process. So it's not always expected bacteria. Look at I'm going to show you Mycoplasma pneumonia, Mycoplasma in neonates. It is not what we are expecting. And look at the frame of work of this patient. This was an admitted patient at 13 days of birth. He was a preterm baby of 35 weeks, no other risks, and he was intubated. He didn't have a good evolution. He was started on cefotaxime linezolid because on first-line therapy he was not improving. And when he was intubated, we did, before the intubation, we did the respiratory panel. And with what we was looking was perhaps a virus, since the RSV, metapneumovirus. What we were not expecting was the Mycoplasma in neonates. Is not always the typical bacteria that you are looking for. The typical bacteria in neonates are also always, or perhaps almost all the time, related to the mother to child transmission, like Uroplasma uraliticum, but not Mycoplasma. And when we had this result, we change our therapy only to azithromycin, and we stop all the other antibiotics. So we did make the direct therapy for the patient that otherwise we will not be coverage. Perhaps with 13 days of age, we will not think in a typical bacteria of the mother to child transmission. And I want you to know that we had 6 days of delay in the correct diagnostic, because before the antimicrobial stewardship program of my hospital assessed the patient, the NICU didn't use the molecular testing. So because if they didn't use it, only they were making this high coverage for normal pathogens, and the clinical deterioration was perhaps related to the absence of the correct coverage for the typical bacteria that we correct diagnose 6 days after admission. If we probably detected this pathogen very early in the admission, we could cover the mycoplasma really early, and perhaps the clinical spectrum of the evolution of the patient could not be the one that the patient had. So I want you to show other panels for you, other strategies in other common diagnostics in pediatrics and NICU. So we are used to diagnose diarrhea in the concept of inflammatory diarrhea or not inflammatory diarrhea. And we are very prompt to diagnose bacterial diarrhea if these are inflammatory. But as you can see, I work in I call it like a battlefield hospital, because I have this population that has limited resources and they are exposed to absence of maternal milking process, and they have this culture administration or cultural administration of other food different to breastfeeding. So this is the first case. It was a term neonate with 17 days old on admission, with 2 days of liquid stool with blood and mucus. And I want you to see that the coproscopic was inflammatory. It has more than 25 leukocytes in the count, and PCR and procalcitonin was negative and normal hemoleukogram. And we did, because of the age and the suspicion of sepsis of gastrointestinal origin, we made the order for gastrointestinal testing in molecular testing, and we detected rotavirus. That is the most common viral detection pathogen, even in the presence of the vaccine for the pediatric age below 3 years of age. And we had also, as you can see, neonate, also neonate, with only 1 day of liquid stool with blood and mucus, also an inflammatory coproscopy with normal laboratory at admission, but with high risk clinical scenario, because it was fed with rice, water of rice. That is like a food that is very common here in my country, that is administered to our neonates in some settings. So because it was not on breastfeeding, it has all the risks for other pathogens, and as you can see, it was only because of the molecular testing that we could not only detect the rotavirus, but also Shigella and Campylobacter. And I want you to tell that even in the absence of this molecular testing, perhaps we could initiate cefotaxime because of the inflammatory coproscopy, right? But if we didn't have this molecular testing, we will not be able to see Campylobacter. And Campylobacter is not covered with cefotaxime, not either ceftriaxone. So we need to make the switch to azithromycin or clarithromycin. And as you can see, it was only because the correct use of molecular testing that we can do directed therapy for our patients. We can do 2 things. For the first patient, we stop antibiotics and we give the alarm signs to the mother, and we discharge the patient. And in the second scenario, we change the coverage to azithromycin, and when the clinical evolution was really good, we discharge the patient with oral antibiotic, without having to have the patient admitted in our floors. So this is another patient. He was a term baby with 1 day of fever, irritation, and lonely lesion. I will describe to you the lesion because this is only the scar. But when he was admitted in the first day at 7 days of age, the physician described a single vesicle type lesion on the upper right arm with an erythematous base, otherwise normal physical examination with no notion of contagion reported. This is what the physician described in the physical examination. No relevant risk for the patient, and the correct diagnosis perhaps will be late onset sepsis or loss. But what was made for this patient, because he was good looking, was this being discharged with a paracetamol or acetaminophen with diagnostics for viral prodrome. So no other tests were made, and this is a neonatal patient. The correct workflow must be admission, observation, and paraclinical testing according to clinical status. I will show you the evolution of the lesions, but I want you to tell you that this patient was readmitted 2 days after. And 2 days after, he had these 3 days of persistent fever, increased vesicular lesions, as I will show you right now, like this type of lesions, hypotonia, low feeding intake, and this peripheral glucose of 40 milligrams. This is hypoglycemia for the patient. It was interpreted at late onset sepsis, admitted with antibiotics. No antivirals were initiated, only ampicillin with amikacin. No lumbar puncture was performed, and no prom IT consultation neither. And as you can see, the correct workflow has to include lumbar puncture, and perhaps because of his focal symptoms, neuroimaging. So this is his lab test for the moment. As you can see, the hemoleukograms show leukocytes, perhaps in the admitted or the tolerable count for a neonate, and ID antimicrobial stewardship. We made an order for lumbar puncture, and this was the result. Only one cell in the lumbar puncture test, only one cell. And as you can see, the proteins were normal. Glucose is not really evaluated because he was hypoglycemic, but I want you to show that even in the absence of cellularity in the lumbar puncture, in the CSF, we have always, when our clinical picture says meningitis or encephalitis, we always have to order the molecular test we have next to us. We have learned during these 7 years of worldwide use of molecular testing that almost 35% of neurological involvement or neurological CNC infection have normal cellular counts in the testing, in the cytochemical testing. So cytochemical testing is not the one that is going to give us the information. If the clinical approach said to you that this could be meningitis or encephalitis, or the clinical picture said to you skin, eye, mouth, probably related to herpes virus, you must do molecular testing in the CSF. This is new because when I was training in ID, the first thing that was taught to me was that you must wait for the CSF results, and only if CSF results are abnormal, you should test for molecular testing. What we know now in 2024, as I already said, is that when you have the clinical suspicion, you always have to make the molecular testing, as I will show you. You know, this is a normal CSF. So with this clinical scenario, the relevant question is if you are going to adjust your clinical approach. And what we did in ID, even with a CSF negative, and of course all negative cultures, was suspecting herpetic encephalitis. We make the decision to start acyclovir on stat, and always performing molecular testing, as I already highlighted to you. This was the detection, herpes sample 1, And we also had the chance to suspend antibiotics. The antivirals, the acyclovir was continued, but um, the evolution for the patients was he was dead uh, even with antiviral started. But I want you to know that uh, if we were able to do this decision making for the patient really quickly, if we can have the tool POCT on the patient's bed, perhaps the story will be different for our patients, because mortality rate for herpes encephalitis is almost 90% without a prompt antiviral treatment in the first 72 hours of diagnostic, and this patient was delayed in the diagnostic for 5 days. So even with diagnostic, if we are late for the patient, perhaps we're going to have death or any sequels or complications. So this was an obvious case, yes, but even with this obvious case, the correct interpretation of the clinical scenario was not made, and the correct implementation of the tools that we have by our hand was not implemented. And this other clinical scenario is really relevant because he's in the NICU, and he's in the NICU with this good photo of him. You know, this could be the beach, and he's really happy. He's really well, good looking, and he was 8 days when he was admitted. No relevant risk scores for the evaluation at admission, and he was admitted because one febrile peak, even to 39 degrees Celsius, with 3 painful stools, and there was no clear event of hypotonia or seizure described for the mother, so late onset sepsis was suspected. And because of the abdominal distension and the painful stools, NICU thought it was a necrotizing enterocolitis clinical case scenario, and they classified the neck as 1A for Bell criteria. This is the admission labs, as you can see, really low risk paraclinical test and a normal abdominal X-ray. And what you really have to have clear is that when you are absent of clear diagnostic in a late onset sepsis, you must do a lumbar puncture. So in antimicrobial stewardship, because they didn't call ID, we did the antimicrobial stewardship consultation. We were looking at good looking but febrile neonate. We ordered a PL, trying to search for the focus of the clinical case scenario, and what we had in this case was an abnormal CSF count. So what we did was a clinical suspicion of enterovirus neuroinfection, and LP was ordered. These are the results with the cellularity altered, but as I told you, there is no need. When you have the clinical suspicion, febrile seizures, you have always to do lumbar puncture and to do molecular testing. And as you can see, this is the result, enterovirus. And when you have the result, you can do the adjustment for the therapy. So we discontinue antibiotics, and we said to the mother, he's going to be okay, he doesn't need to be in the NICU, he's going to be infected, you can go for the consultation for your pediatric consult in the ambulatory setting, the outpatient setting. So we had this early discharge without complications for the patient. And most important of all, we have the diagnostic, and we were able to stop the antibiotics. So in clinical picture, not so obvious, the molecular testing is also a really helpful tool for us. So it has what I call the double flow. It has implicit advantages. So you can rule out what you don't have included in the test. So that is why it's important to have a number of targets really high, so you can rule out what is not included in what is included in the test, and you can reassure what you are diagnostic in the test, and you can redirect therapies or redirect diagnostic when you don't have the pathogen included in the test, so you can do the first approach with molecular testing, syndromic molecular testing. You are going to rule out what is negative in the test, so you can have an impact even in the no detection result. You can have the reassurance if you have detection, and if you are ruling out everything because it is totally negative or not detecting anything, you must direct your efforts to other molecular testing or other tests for other different or differential diagnostics. So this is what I call the double flow, and I will show you these important cases. This was one of my patients with a congenital heart disease. My PQ has the advantage that we can have these high complexity molecular surgeries. So she was admitted because of the congenital heart disease. The correction was made, was a correction of the aorta and a double outlet tract of the right ventricular. And she had this history of a bacteremia for Pseudomonas aeruginosa, an UTI for E. coli, and a pneumonia for COVID, for coronavirus, for human coronavirus, different for COVID virus. This was her previous treatments: cefepime, vancomycin, ampicillin, cefotaxime, amikacin, and these are her relevant laboratory tests. They already use BCID panel in their first deterioration, and the previous use pulmonary pneumonia panel when we detected the coronavirus not related to COVID in November 22. So how the double flow works? When she was on PQ, she was deteriorating after the last antibiotic treatment, and what we had was clinical deterioration. Of course, we had to act in concordance, so we ordered all the sepsis workflow, including new blood cultures, and because of the previous detection of Pseudomonas aeruginosa and the high risk for emergence of resistant pathogens, we had to initiate at that moment in that year meropenem, vancomycin, and colistin. In that year, we didn't have the possibility to have ceftazidime, bivactam, or not novel therapies, so this was our best approach for that moment. What we had really quickly was a preliminary report of yeast in the gram, and we ordered a film array BCID panel, and we quickly started on caspofungin. And what we can see is that the same day that we ordered the panel, we have the detection of only Candida albicans. So in double flow, we can rule out the pathogens that are not being detected by the panel, and we can reassure what we are detecting, in this case Candida albicans. So what we did was stopping meropenem, vancomycin, and colistin, and only having the caspofungin initiated, and the clinical course was favorable. The blood cultures 6 days, they you know that the fungus, at least Candida, has this low growth in blood culture, so the delay is considerable. Look, 6 days for the final result, and we changed the life for the patients the same day we made the test. So double flow, only Candida albicans detected, only caspofungin initiated and sustained. It also shows us that polymicrobial bacteremia does exist. When I was training in ID, it was common for me only to expect that blood culture report for me was a bacteria or a fungal, only one. And as you can see, this is a malnourished child. It's from indigenous population here of my country, with an skin, the first immunological layer of fighting against antimicrobials, against microorganisms, is really altered with severe malnourishment, and it was admitted because of sepsis, fever, neurological deterioration. So sepsis workflow was made, and as you can see, I didn't believe in this gram when the nursery came with this result of the gram. So we did 3 different blood culture sets. I take two bottles. My microbiologist take took other two bottles, and the nursery took other two bottles. And in all the six samples, we had this polymicrobial gram, and we had to call bioMérieux and said them, okay, perhaps the machine is like damaged, and they said no, it's correct, and you have six samples, well taken samples. You must try to isolate, and that's what we did. We in selective and differential standard cultures, we have the isolation of each of the bacteria that was detected on the panel, and this is really reported of it is common 2 or 3 pathogens, perhaps 6 is not the common reported pathogens. There are only 4 reported in the literature of 6 pathogens detected, but it shows us that polymicrobial bacteremia does exist, and we have to look beyond of a conventional routine test. And this is the clinical application of this mechanism. This is a patient that we had admitted. She was a 16-year-old, 16-month-old Venezuelan girl admitted to our PICU initially for pneumonia caused by parainfluenza and rhinovirus. We initially stopped antibiotics because we had the detection and virus can cause pneumonia. But after the surveillance, we have group, he needed intubation, and we needed to start antibiotics because of suspicion of bronchoaspirative pneumonia. After 5 days, it was stopped, and in day A, in the 8th day, she had deterioration. We thought it was another pneumonia, but as you can see, a gram-negative bacilli was reported on blood cultures. And what we had at day 5 was Klebsiella oxytocca report, only Klebsiella oxytocca. But we ordered really early in the treatment the BCID panel, and as you can see, the BCID panel shows us that we have Enterobacter cloacae, not only Klebsiella oxytocca, but also Enterobacter cloacae and also Candida tropicalis. And if we didn't have the opportunity to make this kind of molecular testing, we couldn't be able to adjust the therapy, and perhaps the evolution was not going to be well for the patient. So what is the difference between molecular and routinary tests for blood cultures? That there is microbiological competence in the standard culture. The first one that had the opportunity to grow is going to grow, and he's going to eat all the food, so you can expect to be expressing the other bacteria or inclusive the other fungal structure or pathogens. So this is really of high importance when you have this double flow mechanism of interpretation for BCID panels. Also, pneumonia can be caused by virus. This is a 3-year-old female with chronic kidney disease with this chest X-ray, bilateral pneumonia with a influenza, a pandemic influenza detected in FilmArray respiratory panel. Yes, we could say that this is also only for influenza, but with his immunocompromise, we did agree with the treatment with cefotaxime, with cefepime-linezolid first started by the PICU. But when she was on PICU with a renal replacement therapy and with this support, hemodynamic support, she was intubated, and we also did this pneumonia FilmArray panel, and we applied the double flow mechanism. As you can see, even with a very sensitive test, we did not detect any of the common expected pathogens for pneumonia, and we only were detecting influenza. What it showed us is what we learned from COVID, that a virus can cause pneumonia. We stopped antibiotics, only started on oseltamivir, and she was dead, but she was dead because of the events of tachyarrhythmias, and tachyarrhythmias are related to influenza. She was not dead because of superinfection, and she didn't have antibiotics. And this is something we also have learned from ECMO patients. We have this external membrane support for patient respiratory membrane support, and there are a lot of patients with rhinovirus, metapneumovirus, syncytial respiratory virus, adenovirus detected, and they are on extracorporeal membrane support without antibiotics. And this is, of course, achieved because we have diagnostic tests. And remember what we learned in medical school. We learned that all things that were we seeing beyond 5 years of age are caused by a mycoplasma. But as you can see, 90% of asthmatic crises are caused by virus. This was a patient admitted with a severe asthmatic crisis, and pediatrics consider a pneumonia because that was deteriorating on the evolution on the clinical course. So the initial management or the common treatment that we offer without diagnostic test is usual macrolide and ceftriaxone. What we did in antimicrobial stewardship program with ID was saying that we had a low consideration for bacterial pneumonia, community-acquired pneumonia, and that we had to make diagnostic. This was the chest X-ray. As you can see, no consolidation, no formal consolidation, and including and even in the presence of one consolidation, virus can cause it. But in this case, it was absent, and we had the detection of parainfluenza virus 2 and adenovirus. What we did was suspending antibiotics and giving a correct discharge. And also what we have learned and what we can achieve with correct diagnostics is directing therapy of what you can see. This is a female with Down syndrome, 16 years of age, with this clinical course with focal findings in physical exams and a chest X-ray that is, of course, abnormal. As you can see, this is a bilateral pneumonia, but this is a patient, yes, with Down syndrome, but without oxygen supply, with good clinical looking, and without the respiratory panel. Perhaps we will initiate ceftriaxone, like at least ceftriaxone, and perhaps for the bilateral clinical spectrum, we will add vancomycin or perhaps linezolid. What we did with the correct testing and the correct diagnostics was only initiating azithromycin and giving discharge with oral therapy because she was not using oxygen supply. And of course, what I have shown you is that molecular testing is very important for everyday daily practice. But for example, this 7 years old that had a clinical acute worseness of her previous persistent upper and lower respiratory symptoms had influenza, pandemic influenza, yes. But look what I want to show you. It was from indigenous community, severe malnourishment, and a chronic history of respiratory symptoms. What we did was documented influenza and search for tuberculosis, and we used another molecular testing, in this case GeneXpert, and we detected in the second sample the tuberculosis. So you have to integrate the molecular testing inside the clinical spectrum and the patient you have in front of you. So don't forget tuberculosis, and we are finishing, and I want you to say to you that patients get sick from what the doctor knows, and that is something that any ID doctor will tell you. But in Catholicism, there is this saint that is Saint Thomas Aquino, and he has this famous phrase: you have to see to believe. And medical doctors we are really proclive, we are really propense to treat what we can see. So let's see what the patient have, like make correct diagnostic using molecular testing, so we can have better clinical decisions making. It is going to give us another important tool. So in epidemiological aspects, we can have this data of what is circulating in newborns, what is circulating in other population, including adult population, so we can predict what is going to happen, where we're going to have the respiratory peak for our patients, and how is the behavior, the overall behavior, so we can take health public policies for our patients. We can have right now in Colombia, this is the before peak of influenza. Right now, in October, November, December, we're having the second peak of influenza, and you can have this data in syndromic trends, and this is data generated of the data that you have when you diagnose your patients. And you also can have tools for containing outbreaks. So when we were having an outbreak of Candida auris, that is, an emerging pathogen that is usually multi-drug resistant, and I had one of my neonatal patients with Candida, with a blastoconidia, a fungus detected in the blood culture. My first insight was, okay, I had a change in my NICU personnel. I had this therapist, this respiratory therapist that was changed from adults. Perhaps I'm having also an outbreak. Let's make a sepsis film MRI or BCIT panel to everyone that has the detection of this yeast in the blood culture, and in all the cases scenarios we detected the Candida auris really quick, and we were able to suspend antibiotics and also to initiate caspofungin. And this is really important because when you see a yeast in a neonate, you're going to start on amphotericin, not on caspofungin. But what really have coverage for our Candida auris in my country is caspofungin. If I hadn't had the chance to have this molecular testing diagnostic in my outbreak, I couldn't perhaps make the correct treatment choice and have mortality. The adults have 60% of mortality rate. I had 0 mortality rate because I had prompt diagnostic and prompt therapy. It could also detect outbreaks. This was one of my first outbreaks for Neisseria meningitidis. This is my first patient, and this is his cousin, and we had this quickly detection for Neisseria meningitidis, and this could this lead us to have this prophylaxis for contacts and to advise our publicly health policies. You can start epidemiological trace for trying to avoid more outbreaks. And remember all the other life-changing platforms and the other life-changing test. This recent launch test for joint infection. This is my case, a 16-year-old with polyarthritis. I thought it was Neisseria gonorrhea because he has sexual activities, and it was because of the panel that I could detect it. Otherwise, I couldn't perhaps detect it, and the coverage will be really different because when you have septic arthritis, you're also always thinking in Staphylococcus aureus, not Neisseria gonorrhea, but in the correct spectrum and correct clinical approach and correct testing, you are going to have really answers. Remember, early detection for HIV patient exposed of their maternal risk, tuberculosis, congenital CMV, PCR for syndromic panfungal detection, and PCR for other viruses that are also really important to have in our laboratories. Now, finalizing, I want to tell you that you can have Real, that's a software you can implement to have these boxes adjusted of what you are going to need to have real-time clinical data and results of the testing that you are doing for your patients. The routine clinical molecular microbiological testing and including the molecular test. So in antimicrobial stewardship, including what you have with molecular tests, you have to measure yourself so you can have a correct program. And I want to tell you that what we almost do is suspension of antibiotics almost 60% of the time. And with molecular testing, we are showing our pediatrician in NICU, PICU, and in the ward that you can have really security. And this is the adherence to recommendation of antimicrobial stewardship programs after we included molecular testing between our daily practice. So you have to look for clinical impact. This was before IT rounds, and you can see only 9 detections of atypical bacteria, but 99 coverage of atypical bacteria. So you were not implementing the result in the clinical scenario. So we must learn, and what we learned was this, that if you're going to use the guidelines of the ITSA for a pneumonia in adults or pediatric population, and you are thinking of including macrolides, you have to make testing. And if you see a typical bacteria, it is authorized. Otherwise, we are going to suspend the macrolides. The clinical impacts must be relevant, and I know this is in Spanish, but I want to show you how pediatrics order all the time molecular testing. This is until June 2024. It's a routine laboratory test for pediatrician. We are very well educated in molecular testing for detecting viral pathogens. But look what happens in adult population in my hospital, and we are targeting this. In pandemic time, they were also ordering a syndromic test, but after pandemic, they are thinking viruses are a mythos, are legends, and they are not using diagnostic tests. So the prescription rate is has a low rate, below 98% for adult population, and we're trying to teach them that they are also affected 82% of the times. Viral consultation in adults are related to viruses or atypical bacteria, and you have to make diagnosis to have clinical impact for your patients. Time is important. You have to make critical value like a troponin, as I say to you. This was the first time when the panel arrived for our country in 2006, and the results lasted for almost 3 to 4 days. This is not what is intended to. It's 1 or 2 hours, so you can have the result and take decisions. Time in diagnostic is life, and you also can have what we publish data of the high peaks of atypical bacteria and the low rate in other seasonal episodes of the year. So if you're going to use azithromycin, clarithromycin, you have to make diagnostic testing so you cannot overuse antibiotics. Be aware of clinical criteria, the interpretation, the correct interpretation, and this is my proposed evidence-based workflow. Every time you have an admission for hospital-related pathology, you must do at least respiratory film array. If it's intubated, you have clear suspicion of pulmonary focus or pneumonia. And if your gram is checked by microbiologists and is pathological, or you're suspecting a bacterial and viral etiology, make a film array pneumonia in bronchoalveolar lavage, mini bronchoalveolar lavage, or sputum, or the endotracheal aspirate specimens. If you have blood culture with at least 2 bottles with growing of gram-positive bacteria, or at least you have 1 bottle with gram-positive, but you have clinical sepsis, is a patient in sepsis, you undoubtedly have to prescribe the film array of sepsis. And any GIST and any gram-negative in blood cultures must be performed with sepsis film array or BCID panel. And in diarrhea, you have to if you have 3 days without response, or you have sepsis of gastrointestinal focus, you have to make the correct election of the test. And don't forget what I show you. If every time you suspect neuroinfection, even in the absence of a CSF abnormality, you must perform whatever molecular test you have for meningitis and encephalitis. And nowadays that you have film array point and joint for septic arthritis whenever it's possible, and this is the workflow that is proposed. The patient clinical correct assessment, the workflow, laboratory antimicrobial stewardship, correct test, correct patient, correct time, a POCT test order, the standard microbiology test, the POCT test, fast and real-time results like critical alert like troponin, so you can do ASM interventions, correct interpretation, correct antimicrobial, correct time, route, changing or switching to oral route every time is possible, the correct duration, so that is possible because of diagnosis, and you can have the correct treatment. My take-home messages: integrate the molecular testing process into the clinical daily practice of your life and make it a critical value alert. Not only the early order is important, the correct interpretation is important, and decisions must be implemented on the result in a timely manner and in real time, so use software. infectious diseases monitoring antimicrobial stewardship, or ID consultation, optimizes the use of antimicrobials, directs therapy, and improves prognosis in every clinical scenario. Molecular syndromic test provides diagnostic opportunity, guides therapy, allows cohorting or isolation, identification, and containment of outbreaks. Thank you very much. I think I stopped sharing my presentation. I don't know. Yes.
Okay. Thank you, Dr. Arias, for such an outstanding and insightful presentation. I will check at the Q&A box if we have questions, or in the chat box. I will find one in the Q&A. One question is, in neonate, which panel is more useful if I had to choose between respiratory or pneumonia panel?
It depends of the sample you are going to obtain. If the patient is intubated, I will prefer pneumonia panel because it will detect not only bacteria but also viruses. Perhaps the difference between pneumonia panel and viral respiratory panel of upper nasopharyngeal swab is that the pneumonia panel is not does not discriminate the type of influenza virus. It will only say to you influenza virus. It will not discriminate to you the type of coronavirus by the coronavirus detected. It will only say coronavirus, human coronavirus. But it depends. If it's intubated, of course, always pneumonia panel. But the usually admitted NICU neonates are bronchiolitis, viral pneumonia, that are requiring high flow canal nasal cannula, and in that setting the respiratory panel is very useful, so you can choose really quickly to make the viral diagnostic or the atypical diagnostic, and really quickly suspend antibiotics that are otherwise initiated when you're suspecting the co-infection, the bacterial co-infection. When you see that it's really viral or the atypical bacteria, you can choose not to have antibiotics or stop the antibiotics, or initiate correct initiation of macrolides in that scenario.
Thank you. I have a question because it impacts me on the how the improving of the using of the antimicrobial in your hospital using this diagnostic testing. Do you also know what was the financial impact in the hospital being able to have this molecular diagnostic platform in your hospital?
Yes, we have some clinical data. We low the prescription rate of antibiotics in respiratory settings, 76%. So when ASM, antimicrobial stewardship, that is directed by ID doctors, are going to see now the patients, they are already without the antibiotics prescribed. You know, the pediatrician has already the insight that is viral and they don't need the antibiotics. And it also changed what we call the discharge rate, right? Right now, the occupation rate for the respiratory admission in our patients that don't need oxygens, it's improved like 50% of the times. It's more quickly discharged the patient. And in terms of antibiotics duration, we had this previous 18.2 days of duration of antibiotics. Now, with molecular testing and antimicrobial stewardship program, we have a medium of 5.6 days. That is really amazing. I mean, the change of the pattern of antimicrobial prescription has changed totally. And in meningitis encephalitis, it's a life-changing scenario because we were used to call the absence of detection in cultures like anaseptic meningitis. What we are looking right now is that at least 35% of normal CSF are have an infection cause, and you can choose to correct initiation of acyclovir or to stopping in the case of parechovirus, enterovirus, and detection in immunocompromised hosts like varicella zoster virus, cryptococcus pneumonians.
Thank you. Another question I have was that you show that after the COVID period, coronavirus period, in adults, the use of molecular diagnostic has distinguished. And in comparison with the neonates and pediatrics, it's quite amazing. I didn't understand quietly why it comes that it's not being used in adults, seeing all the positive results the neonates and the pediatric department have.
I think it's an educational issue because when H1 influenza in 2009 was affecting us, it was the same, and we learned only about influenza. And now with COVID, we learn only about COVID. After COVID pandemic was free, so adult population always think that asthmatic crisis is because of bacteria, and that chronic pulmonary exacerbations are caused by bacteria. The guidelines also make this clinical approach. They don't make the stop, and they don't guide you to make diagnostic. Is until this year that the adult guidelines are suggesting making viral diagnostics. So before this year, the guideline was you are suspecting an acute exacerbation of the chronic pulmonary condition or asthma, or are you suspecting a clinical infection, start on ampicillin, sulbactam plus clarithromycin, or start on levofloxacin. So when the guideline didn't guide you, you are willing you're willing to not using diagnostic. So I think it's more because they don't make the diagnostic that they don't use the test, and because they don't use the test, they don't see the virus, and because they don't see the virus, they don't believe in the virus. So it's important, it is critical, because at least for me, being an IT pediatric specialist, what I am most focused this year is teaching adult population that viral and atypical bacteria exist, must be confirmed. And it's ironic, Emily, is that the next 5 respiratory vaccines available that are coming in the next 5 years are for adult populations. And I'm always wondering, what are we going to do if adults don't believe in virus, so because they don't search for them, for making the adult populations being vaccinated for viral pathogens? We have right now influenza, COVID, and right now RSV for adults. And what is going to be the coverage for RSV if the adults doesn't diagnose RSV, right?
Okay. Now, I'm also curious about the development of the usage of the antibiotics in your hospital, being able of detecting more earlier now with molecular diagnostic. Was the evolution also that better antibiotics are used, or
yes, is related to better antibiotic use, because at least for example in double flow mechanism, when you start a patient that is critical, is sick with meropenem vancomycin, for example, and you at 9 hours have a gram-negative bacilli growing, and you make the BCID panel, and you're only seeing pseudomonas, why are you going to need vancomycin? You don't need to wait for the culture so you can stop vancomycin. So it's really amazing, because you're always teach like after 28 hours without growing anything about the Staphylococcus aureus, you must stop vancomycin. But let's see how many clinicians in a septic shock is going to take that decision. It's not really an easy going direction, or easy going clinical workflow. So when you have the panel and you see Pseudomonas or you see Acinetobacter only in the BCID panel, you're going to stop vancomycin really early, and you're going to avoid all the adverse events, and you're not going to need the levels being checked, and you're not going to have this nephrotoxicity related, right? And it goes beyond when you have only the gram-positive detected, so you can see, okay, I'm going to only with vancomycin, not going to use meropenem, right? And for the resistant genes, for example, as I show you in the Pseudomonas case, if you have these Pseudomonas detected and not the common relevant genes that are detected, or Klebsiella pneumoniae and no KPC detected, and no CTXM detected, you're not going to expect an extended spectrum beta-lactamase. You know, the CTXM gene is representing right now the 98% of the extended spectrum beta-lactamase. So if I don't see the gene, perhaps I'm not going to need meropenem. I could start on cefepime, and that's going to impact your consume of antibiotics and your DOT, your days of therapy, and your DDT, daily dose of antibiotics. And what is important, Emily, is what you're trying to say. When you start implementing molecular testing, you must measure, you have to have the clinical data of what is improving in your institution. It's not only that I'm using it, it's what is making what changes are making you in your clinical decision, in your clinical practice. I show you, we use 6,000 respiratory panels before ID started in a hospital, and the clinical implementation with the result was not really good. Everybody was seeing the result, but nobody was taking action with the result. You must take action. It has to change your daily practice and your prescription and your orders, and if you don't do that, if you don't measure that, then you're going to be bored with the laboratory test, because it's not going to make you any life-changing paradigm for your daily practice. So you have to measure, and that's the importance of implementation and clinical data of what are the improvement in your institution.
Thank you, Dr. Arias. Since we are coming to an end, I want to check again if there are more questions. Otherwise, if there are no more questions, I want to thank you, Dr. Arias, first for your outstanding, insightful presentation. Your depth, knowledge, and expertise in pediatric and neonatal infections, combined with practical example, has truly shed light on syndromic diagnostics in improving patient outcomes. On behalf of PanelPax and everyone, I want to express our sincere gratitude to make this webinar both informative and engaging. For the audience, I want to thank you also for participate, and we are looking forward for the second presentation of Dr. Arias. Please save the dates. It will be in the first week of February of next year. We would like to invite you from now to join us and get more information about molecular diagnostic stewardship. Thank you again, and we will keep in touch in the first week of February.